started with our next panel. And this panel is focused on strategy, what to do now and over the next 5 years. We've got a tremendous panel. Javon, why don't I start with yourself and go left to right and ask you to introduce yourself and just give a few moments on background in the system you've driven the last 10, 20 years now.
Sure. Can you hear me in the back? Okay, great. Javon Bay, President and CEO of Mercy Health System. We're headquartered out of Janesville, Wisconsin. We have 69 facilities in 28 communities, primarily in southern Wisconsin, northern Illinois. I've actually been at Mercy, I don't really want to say this, close to 25 years. We had a vision back then to form a vertically integrated system. Today we've got 3 hospitals strategically located. We have a number of what we call hospitals without beds. We employ under a very unique model called the W-2 Physician Partnership Model, over 400 physicians that make up 52 specialties and subspecialties. This particular model meets all of the requirements of the IRS so that they are considered, in the eyes of the IRS, employees of the health system, but actually they function as if they're in private practice. We did form about 18 years ago back what's called Mercy Care Insurance Company. We now have 11 insurance products, including Medicare Advantage. We're big in the post-acute care. We have 14 retail pharmacies, a health mall, home health, DME, and so it's we really have set out over the last couple of decades to build this vertically integrated system. We've spent a lot of time with our physicians being part of the system and the insurance company learning how to manage care, develop clinical protocols, and I just find that it's much easier to do that across the entire patient continuum, from the physician office through the hospital, through the post-acute, when the physicians are partners with the system, complete partners, as everyone else is with the system.
Barb?
Good afternoon. I'm Barb Martin. I'm the President and CEO of Vista Health System, which is a local system up in Waukegan, Illinois. Waukegan is the county seat of Lake County. And we are, as Vista Health System, we have 2 acute care hospitals located in Waukegan, and we have, as I say, a hospital without beds, inpatient beds in Lindenhurst, which has a syndicated surgery center, freestanding ED, medical office building, employed physicians, full imaging, MRI, et cetera. We're hoping to build a new hospital at that site, inpatient beds. As you know, though, Illinois is a CON state, very difficult and a lot of opposition. As part of Vista Health System, we are, about 6 years ago, I led an acquisition with Community Health System is who we ended up with. Community Health Systems located out of Nashville, Tennessee, and they're the largest publicly traded company in the nation. We were a Catholic hospital and an independent community hospital when the acquisition occurred, and frankly, I came up there to lead a turnaround, and we were profitable, but we had no money in the bank. So we joined Community for cost savings, effectiveness, and it's been a great acquisition working with them over 6, actually going to be 7 years in July.
Barb, how big was your system revenues-wise then and now?
Revenue-wise, at that time, we were probably, thinking back, a little over $500 million. Now we're certainly over $1 billion. And again, we continue to work we serve the poorest of poor and the richest of rich. And again, a lot of competition. We also employ doctors. 6 years ago, we weren't employing any. The strategy up there in the 90s, we all failed, though we are actively acquiring physician practices from our competitors, as well as we're recruiting and have been very successful in we call it Vista Physician Group, in being successful with doctors. We also work independently with our current doctors, because if I'm known as anything, I'm a physician-friendly CEO, and although it can go against doctors' grain to employ doctors if they're independent, I always go to them first and give them the opportunity to join Vista. If not, then and we have a need, we will go out and employ specialists and or mainly primary care and internal medicine physicians. But again, a smaller system, but yet part of a very larger system that's been great.
Great. Andrew?
Good afternoon. My name is Andrew Racine. I'm the Chief Medical Officer and Senior Vice President at the Montefiore Medical Center in the Bronx. My background is I'm a general pediatrician. I'm kind of reminded that there are probably enough people in the audience who remember a former senator from North Carolina who used to introduce himself as just a Paul Country lawyer from North Carolina. I'm just a poor general pediatrician from the Bronx, and that's an interesting background to become the Chief Medical Officer. Montefiore Medical Center is a large system of healthcare in the poorest urban county in the United States. We're a single-payer system in the sense that 80% of the patients who come to see us are either Medicaid, Medicare, or dual eligible. It's a large system. We have now 5 hospitals. We take care of about 500,000 people, which is a third of the Bronx. And we have what was an ACO before there were such things as ACOs. We've become a pioneer ACO as of January 2012, but the system includes not only hospitals, but it includes a large ambulatory network of physician practices. About 22 practices look after about 300,000 people. All of them are employed physicians. We have a home health agency that does about 700,000 visits a year. We do about 600,000 ED visits a year, 3.5 million ambulatory visits a year, and about 100,000 discharges. In addition to the ambulatory network, we've got a care management organization which employs about 800 people, all of whom are responsible simply for navigating the health services resources for the people that come to our system. They concentrate mostly on folks who are chronically ill and who have severe issues, but it's been a long-standing tradition within the medical system that we work at, the recognition that most disease has social origins and that what we do in the healthcare field, meaning in the hospitals and in the exam rooms, is just really a marginal impact on people's health, whereas if you really want to make big impacts, you have to be out in the communities where they live. So there is a lot of work to be done in that area, but we've been very happy with the recent trends within the federal government with regard to ACOs, because we think that this is a real opportunity to try and capitalize on what is our chief strategy, which has to do with population health. Of the 500,000 people we take care of, about 270,000 of them are either full risk capitation or shared savings. So we're well on the way to be doing that in a big way.
Thank you. Linda?
Hi, I'm Linda Hoff. I'm the CFO of Meritor Health Services, and I'm the CEO of Physicians Plus, wholly owned HMO as part of our health services system. We're located in Madison, Wisconsin. Madison is in Dane County, which is about 500,000 people. We have a hospital, physician group, the HMO, and a smattering of other services, home health, et cetera. A unique aspect about Dane County and Madison is the fact that the competition is really at the provider HMO level. Over 60% of members in Dane County are associated with a provider-owned HMO. Very, very unique. That is true across our state. There's 11 provider HMOs in Wisconsin, of which Mercy is about half an hour away, and we almost compete on some things. Our biggest challenge is being between two big giants, one being the UW Hospital Medical System and Academic Center, and then also St. Mary's is literally about 4 blocks away. St. Mary's is associated with SSM out of St. Louis. Recently the physician group Dean physicians joined with SSM, and so we have a significant competition from that perspective.
And was Dean an important referral source to your hospital before this, and does it continue to be the Dean Clinic?
No, Dean was not a referral source. Our referral sources are employed physicians, of which we have about 120. An additional 500 physicians that are part of the UW system also practice at Meritor.
Gotcha, thank you. Nancy?
Hi, I'm Nancy Vish. I'm the President and Chief Nursing Officer of the Baylor Heart and Vascular Hospital in Dallas, Texas. It is part of the Baylor Healthcare System. I'm also part of the team overseeing heart and vascular services for the Baylor Healthcare System. Baylor has about 14 hospitals and about 300 entry points, multiple innovative strategies in business, and is most recently considering the merge with Scott and White.
Well, let's do this. This panel is focused on strategy, and what I'd like to do is focus some on process, just how you go about setting strategy for your systems, but then also dig some into the substance of strategies so people in the audience can get a sense of how they differ or how they should look at things. Javon, why don't I start with you? I mean, you've been at sort of the head of your system for a long time. How did you evolve on developing strategy for your system? Was it a formal process, or was it something that you did incrementally? How did you go about it?
Yeah, I think it really has to do with back at the beginning when we, just from my decade at the Mayo Clinic and at the Mason Clinic in Seattle, I saw early in my career the advantages of having physicians in hospitals work in an integrated fashion. So what's been the foundation of our strategy setting has been vertical integration. And we believe, and certainly as bundled payments come, bundled payments, as they come from CMS, will not be able to support a number of separate cost structures, even through, as organizations try to form ACOs through contractual basis. I think we're going to find the bundled payment will not support all those separate cost structures. So we'll see for the next couple of decades more and more integration unfolding. But that's been at our core, and I think in the 90s when a number of hospitals were forming horizontal systems and understanding the hospital culture, we really delved into the physician culture.
And let me ask you a question about vertical integration and your strategy there. You've ended up with a very, very strong home base, I think in Janesville, where you're really a principal system or the primary system.
Right.
And then you've periodically ventured out much broader than that geographically.
Right.
How important is it to protect your home base, and how important is it as things evolve? How big does that geographic footprint have to be?
I think it really varies in each market. I mean, southern Wisconsin probably has more cows in it than it does people, and so you really have to look at the marketplace that you're in. And we started in Janesville, but we're now down into Cook County of Chicago. So we're in 28 different cities, but we did it based upon unmet need. So instead of, we looked at Madison 20 years ago, and it was glutted with physicians and providers. As Linda was saying, Rockville, Illinois is the same way. So we really tried to go in markets that the need was not met. And that's really been our driver, is where's the unmet need and fill that need.
And how does that work economically in positioning yourself with payers? How does that work for long-term survival? Do you have to be profitable in each one of these small places that you're filling an unmet need? Or how do you work that as
you obviously have to have critical mass. So our Wisconsin market's completely different from Illinois market. And I think, as Linda was alluding to, Wisconsin is highly integrated, and you really have to be in the insurance business. You have to be able to get your share of the insurable market and know how to manage that care to really survive independently in Wisconsin. In Illinois, it's completely different. There, it's more, we are licensed in Illinois, but it's really amassing enough critical mass of providers, which we've done now to get the attention of the Blue Crosses of Illinois. So.
And you've been at that, I know, for a long time. Early on, I remember being on the opposite side of a transaction with you in Kishwaukee a long time ago, and so you've really sort of been back and forth in this for a long time. Right. Barb, let me move to yourself. In terms of developing strategy.
Did we get the better part of you in that transaction?
I don't think, okay. I think it ended up, I'm not sure. But at the time, Mercy was viewed as sort of an interloper into Illinois. So it was sort of a different feel to it a long time ago when you were first touching into different geographic areas, and that still resonates in healthcare today as people move into different geographic areas to spread their sort of their base. Barb, in developing the Vista system, developed it into a serious hub there where you really had a good deal of really developing a strength where people could not go through Waukegan or have payer plans in Waukegan without you. How did you sort of develop the strategy? How did you take the system that was sort of struggling and make it into a very strong system? I mean, you're now a CEO at a community health systems hospital and system where you've maintained a tremendous amount of autonomy. I know that you work 24/7. How did you sort of develop the system into where it's at today, and how have you done so under the umbrella of a larger system now, or a larger chain?
Well, I think although Vista is part of a very large system, community health system, we are very much locally run. We have local boards, and as in setting strategy, we're held accountable on an annual basis to develop a strategic plan that is, a 1 to 3 year plan where we develop our strategies, our core competencies. We look at market share. We look at physician integration. We look at all those components. We'll be starting very soon in August, or really July, August, setting our strategy for 2014. And the key that we do, that we've been successful, is identifying, first of all, looking at the market. You have to have data. Where were we losing market share? Where were we gaining market share? What are the core strategies that are going to take Vista to the next level? Being probably in a system, one of the smaller systems in Lake County, because we have the Advocates and the Northwesterns, and actually Mercy is a little bit integrated into our western part of the market, and we're only 7 miles from the border. So what we really did was look at those core competencies, and one of the key things that we did to become successful is identified that the emergency departments are the front door of a hospital. And, some people don't realize that, but that's where most of your people come in. And we identified and actually expanded Illinois CON. We were the last hospital to get a freestanding emergency department approved in the state of Illinois. We opened about a year and a half ago, and we've gained, we're the only one gaining market share in emergency room business in Lake County. In the western market, we've gained over, I think, about 15% market share in ED visits, and certainly taking that away from our competitor. We also looked at, cancer, cardiology, those different components, and really set that 1 year plan with strategy goals, rolled it out to the boards. I have CEO meetings. All my employees know what our strategy is, because I say to them, you're going to make us successful or not successful.
Could you describe your strategy in a sentence, very briefly? What's the core strategy of the Vista Health System?
The core strategy is to work with physicians, whether it's employ or collaborate, grow market share and grow volume. I always tell when we are having a tough month, volume's the king. And, you bring, whether it's inpatient, outpatient surgeries, and to continue to do that.
Do you see in the near term changes in that volume orientation to the sort of all the discussion of, value-based and accountable care? At what point do you see that transition, or do you plan to retire before that transition happens?
Well, I don't plan on retiring for a lot of years. I think I'll always work in healthcare, probably to my grave. But whatever it is, I think accountable care. Many systems are sitting back and looking at accountable care, and really evaluating it. I think the key strategy that systems have to do is assure that they have strong integration with physicians. I'm a nurse by undergraduate degree and went through that track and moved out of it in 1990 into the hospital operations. And I think the key is you have to realize they're the only people that can admit, can refer, can order tests, order surgeries. And, we've syndicated a surgery center recently where, in Lindenhurst, where the doctors own 49%, we own 51%. We've integrated, we'll employ by practices. Being part of a system, you do have some of the luxuries of the capital. And again, really working with doctors to make them be part of it and make them want to choose your institution over our competitors and move forward.
And Andrew, let me ask you, the strategy of Montefiore in sort of a nutshell, how would you describe it?
There are 4 we had a formal strategic planning process that took place a few years ago, and there were 4 elements to it. The first was a robust co-branding with our academic partner, the Albert Einstein College of Medicine. And that has all kinds of implications. Albert Einstein, for those who are not from the Bronx, had clinical affiliations and still does with a variety of different hospitals. But we wanted to bind them together with Montefiore in a co-branding effort that was going to have implications for high-end activity that we were going to be responsible for at the medical center. So the first thing was the co-branding from an academic standpoint. Second thing was the development of clinical centers of excellence. And this is not going to be something that's going to be unfamiliar to either people on the platform or people in the audience. So we selected cancer, cardiovascular care, pediatrics, because we had a relatively new children's hospital that had opened in 2001, and developing subspecialty activity and subspecialty access. Those four elements were overlaid on this longer-term activity that we've been talking about, wherein we made a decision a long time ago, given the architecture of the system we have, to move forward very aggressively away from fee-for-service and toward capitation, shared savings, bundled payments, all of those kinds of things. The idea there was that there simply was no way to actually make a margin when all of your patients are either Medicare or Medicaid on a fee-for-service platform. You can't do it. The only way to actually manage that is to take responsibility and risk for everyone and manage the care so that you can share in the savings and sort of move yourself up the premium chain, if you will, to get to the point where you're taking first dollar in the premium. So those were the main strategic goals. Now, there were geographic considerations that are specific to the Bronx. We are north of the Harlem River, so we're the only academic medical center in that entire borough. The borough has 1.5 million people. It's bigger than many cities in the United States. We're the only major academic medical center there. And north of us, when you get into Westchester County, there's a whole population of people in the southern tier of that county who, for demographic purposes or from the standpoint of payer mix, look exactly like the people in the Bronx. So we know, having done this for a while among a group of multi-ethnic, relatively poor people, that we know how to do this. And so the following part of the strategy is to extend that activity up through to another 250 or 500,000 people.
Well, let me ask you
in
a
the
couple
southern Westchester
questions.
tier.
One, in terms of against your strategic plan, in terms of the four categories of specialties that you attempted to become viewed as centers of excellence or clinically really excellent, how have you done in that? And then with that, did that take real allocation of resource decisions that you're going to put money into investing in those areas and not others? And then the third question I have for you is just the percentage of non-fee-for-service business versus fee-for-service business that you do.
Sure. So the answer is yes, it did involve a certain amount of investment up front, mostly in terms of personnel, not so much in terms of physical capital, although we did do a fair amount of investment in certain kinds of combined cath labs and things like that, which were going to be necessary for some of the high-end cardiovascular work that we were doing. The thought there is that, and particularly with regard to transplants, which is what we have been doing a lot of, that when you have a city of 1.5 million people, just stochastically, there are going to be a certain percentage of people who are going to be born with cyanotic congenital heart disease. There are going to be a certain number of people with hepatitis C. They're going to need their livers transplanted. There are going to be a certain number of people with diabetes who have end-stage kidney disease who are going to need high-end care. And there is no reason in the world why folks shouldn't be able to get that near where they live rather than have to travel to, God forbid, Manhattan to get that, right? So the idea was that we thought we had a built-in population of folks who come to us for their primary care as it is, who come to us for some of their subspecialty work, and there's no reason why they shouldn't be able to come to us for those things. So that there was an investment that was necessary to do that.
And
but
how successful have you been in stopping the out-migration
Yeah.
of that services?
Right.
And then I want to move on to Linda and Nancy, just so I
absolutely.
make sure I get.
So, and I'm just going to answer one other of your questions. So the answer is it depends on which of the different areas we're talking about. So for some of them, liver transplantation, cardiac transplantation, we've actually been quite successful. And we actually have a long-standing history of renal disease and renal transplants there, so that's been also one of the strengths. There have been others where we still are in competition with Manhattan for some things.
And because you're in a tough urban area, how hard is it to get patients to come into the area for specialty care?
Right, and that's an interesting thing. What we've and again, I know we want to get to the other folks here, so I'm going to just very briefly. In coming back to one of the themes from the previous panel about partnerships, we have also partnered with folks, for example, North Shore LIJ, and folks out on Long Island, because there are things that we offer that they can't offer, that we bring people in at the same time that we're partnering with them so that they will develop the capability to do liver transplants. They'll develop the capability to do live donor kidney transplants. So while they are developing that, we're working with them, and then when they need referrals during the meantime, they'll send them to us.
Gotcha.
In terms of the share of capitation, as I say, we look after about 500,000 people. 270,000 of them are now either full risk capitation, shared
Right.
savings, or something like that.
So a very, very significant degree.
Big.
Linda, you have a hospital, an HMO. How active has the HMO been for the last decade? Has it become more relevant again? How did you go about developing your own insurance company? What were some of the thoughts behind it when you did it, and how important is it now to?
Yeah, the major driver of development of HMOs in the state of Wisconsin was the government in the state of Wisconsin, the incentives in place to form HMOs. So we've been in existence for over 25 years. The importance of the HMO really goes back, if I could revisit the strategy question and how we go about strategy. In 1998, we had a significant event happen. We were vertically integrated. 95% of our care was delivered by one physician group. We had our HMO that covered over 100,000 lives in the hospital. We were completely contained, very happy. We lost our group to the UW Academic Center, which then forced us to re-examine with our board, who are we, why do we exist? Is it important for our community hospital to exist in the community? It really forced a lot of strategy discussions that help shape who we are today. So as they went through that conversation, it went back to revisiting the mission. How would our community be different if we weren't a part of the community, and reinvigorated how we wanted to then position ourselves for the future. So really the strategy comes through the board, not only through these exercises, but also in the selection of members that are dedicated to maintaining this type of healthcare in our community. And just to capitalize a little bit more on that, we have redesigned our board processes to be at least 70% dedicated to strategy. At the end of every meeting, they check in to say, how did we go, how did we fulfill that mission? And there's a couple ways that they do that. It's by continuously becoming educated about things like our HMO. Why is the HMO important to fulfilling the strategy of a community hospital? Does it still fit? About an example of looking at the breadth of our services, about 8 years ago or so, we wanted to understand what was core, what was non-core, how was it helping us fulfill our mission in the community, and we decided at that time that our senior living component wasn't core to fulfilling our mission, so that led to a departure of that.
What's the core focus of the strategy today? You're a single hospital system?
Yes,
And so, how much time does your board spend assessing, can they stay the course as a single hospital system versus all the affiliation activity that's going on throughout Wisconsin and other Midwestern states and throughout the country, quite frankly?
No, that's a great question. They spend virtually, like I said, 70% of their time examining that very question, and there's a couple components. There's the geographic expansion question, and will expanding geographically on our own help us fulfill our mission, or do we need a partner from the outside to help us fulfill our mission? So yes, that's...
And to stay relevant and to stay viable, do you have to excel in certain core areas? And how strongly do you make decisions about what do you abandon versus what do you really focus on? I mean, those must be hard discussions
Yeah.
now.
I think that's a great question, and a question would be much easier to answer if we were just a provider system and not an HMO. It's easy to answer from the provider perspective. In some ways, you can think about what services you do well, what you should be in and out of. But when you own an HMO and are responsible for a population, then it becomes a make or buy decision. for example, behavior health, which is everyone struggles with making that a profitable service line. So we have to put it through the filter of, does it make sense as a provider, but also through the payer filter to say, if we didn't provide it in-house, would we be able to purchase it less expensively outside of our system?
You're almost buying it out of network for your own HMO if you don't have it in-house or you don't have
Right.
great affiliations on it. How aggressive, I mean, the payer contract in Wisconsin, you know, I hear nightmares about the growth and competition, how, you know, how United approaches the market with providers, how others approach the market. How tough is it, and maybe Javon, you could also answer this, how tough is the approach to getting employer business today through your HMO and getting patient business?
You know, there's a contingent of employers that have national accounts, and we've gone through cycles in our business. As I mentioned earlier, 60% of the business is going through one of these local provider-owned HMOs. Yes, they have some geographic footprint in Wisconsin, but not nationwide. We've gone through cycles where we've lost major employers, such as U.S. Bank, to their national account, and because they wanted to have one insurer. A cycle goes through and they realize that if we broke this up and purchased in local communities, maybe we would do better. So, you know, that cycle
Right, and you see right
continues.
now, big employers shopping the different blues against each other, moving headquarters, doing all kinds of things to get better pricing. Javon, how do you see that, the work in the sort of market with your insurance plans?
Yeah, I mean, Linda's right. In Wisconsin, it's different because, like in southern Wisconsin, the Blue Cross, we kicked them out of the state many years ago. It's just us and Dean Care. It's Mercy Care. We have our providers, and Dean Care has their providers. So it's really us and Dean and a little bit of unity bidding for the employer's business. And, you know, we find that, you know, our competitor, provider-based insurance company will come in and try to buy an account for a year or two, and then they can't sustain it at that price, so we get it back. And it's, what I would say is that we really, other than what Linda described, we pretty well have each has our own market share today. It's a very mature market. Now, it's considerably different in Illinois.
But how much concern do you have? You know, you certainly hear the bigger chains in Wisconsin talking about trying to go, you know, up market and take 90% of the payer dollar, you know, and then have them distribute it. How much concern do you have as you compete with the chains in Wisconsin, the large chains in Wisconsin, that they'll be effective in doing that and force you to essentially be a subcontractor to them?
You mean a large provider chain?
Right.
Like an Aurora, et cetera?
So to
you know,
speak.
thank God Ed Howell said 20 years ago he didn't want to be in the insurance business. So, you know, they're a large provider network, but they really don't have any experience in managing care. As Linda will tell you, it takes years of developing the systems, the intellectual capital, the processes for really being able to effectively manage care when you're on a fixed premium per month.
And so to quote
and so I,
you,
know,
so to quote you, you view them as not really competition.
No, you know, it's really, I really don't.
No, I say, but no,
I really don't.
because
I mean,
they've not really developed at this point the whole.
We battle Aurora big time over in Walworth County, and you know, we don't have any problem at all because they're still trying to get their insurance arrangement together. So again, I think in Wisconsin, everybody kind of has their share of the market, and it's a little trading back and forth based on price. And what goes around this year comes back around the next
Right.
year.
If somebody tries to be a low-cost provider, then they
Right.
have a very hard time servicing it,
Right.
and then sort of the business moves around. But let me do this. Nancy, you've got a fascinating situation of running a specific cardio hospital within a large system. Can you tell us a little bit about how you approach strategy, how you interact with the rest of the Baylor system, which is, in its market, a dominant, a very important system?
It's a very integrated process for strategic planning. There is a system board that meets yearly. We do a 5-year plan, and so each of the not-for-profit boards has strategic retreats, and then the for-profit entities have strategic retreats. Those are generally facilitated retreats and are aligned with the system goals and strategies. Baylor Healthcare System identifies by 4 focus areas, which are quality, people, finance, and service. In each of those are goals, and those goals are then distributed from a system standpoint and so each of the entities aligns. Now, because of our uniqueness of the joint venture, we have additional goals and strategies for the entity, but again, aligned. Probably the execution of the strategy is probably the most interesting. We started about 5 years ago, and we cascade individual goals that, again, are linked and aligned to the hospital goals, which are linked and aligned to the system goals, into each individual employee's performance appraisal.
And so, Nancy, how much of your focus is on really strictly the profit and loss of your hospital that you run? You know, how much of it, when you cut through everything, how much of your focus is on, quite frankly, volumes and strength of profit and loss at your own hospital?
We actually, our primary focus has been and always has been since 2002 on quality and safety. And that has been our number one goal. And what we do is through that strategy and identifying best practice and eliminating waste, we ultimately get to our finance goals. And so that has been a strategy that has worked for us since we opened in 2002.
Gotcha. And let me do this. Let me go to each one of you and focus for just 30, 60 seconds each. And what do you see? Quite frankly, as I listen to this panel, there's a significant amount of optimism that I hear coming through from the five of you. You know, I don't hear the trepidation you hear in some leadership today. What do you see as the biggest threat to each of your systems and each of your market positions? And Nancy, why don't I start with you and come back this way? Just 30 seconds, and what do you see as your
I would
top
say,
threat?
as probably everybody in the audience, the biggest threat is the unknown, and it's the unknown of what is going to happen with exchanges as well as the entire ACO model.
Yeah, how much concern do you have about the shift of business to lower-paying healthcare exchanges? How much?
Well, significant concern because, again, we have a very large uninsured population in Texas, particularly in Dallas. And we also have a lot of small employer-based companies. And so there is concern with what will happen with that shift and ultimately to the systems, healthcare systems in the area.
Linda, what do you see as the biggest threat to your system, and what keeps you up at night in trying to make sure you guys remain viable and strong?
Yeah. The biggest threat to our system is probably being able to run the provider side well as manage the HMO, given the size of our organization. And given the fact that the only way the provider side can survive and thrive is by having the HMO do well, and we are in a cycle that's very, very tough for payers, especially under healthcare reform and the risk that is coming through that piece. The other thing that is a major threat is the academic medical center utilizing its monopoly power in our market to, they also own an HMO that is very willing to compete extremely aggressively against us. And then lastly, just bringing, again, all three of these pieces forward in a time of great, great uncertainty. So keeping three very different, when I say three, I mean the hospital, the physician group, and the HMO all moving at a pace that is sustainable for long term.
When you say monopoly power, just for our writers, what you mean is alleged monopoly power.
Alleged monopoly
Right,
power.
exactly. Andrew, in terms of you enjoy a pretty dominant position in the Bronx. I mean, a really dominant position, which is a great position to be in. People really can't go around you for care, at least for day-to-day care. What do you see as the biggest threat to your system?
So as the major academic medical center, I'm so pleased to getting to sit next to Linda. This is just perfect. I started out by saying we are effectively a single-payer system. So the biggest threat to us is what happens or what doesn't happen in Washington, D.C. We have also concerns about Albany, which is the state capital of New York, but because of our proximity to the state capital and our proximity to the folks who work there, we have a different relationship with them. But there's a lot going on in Washington, not simply from the standpoint of what's, to my mind, is sort of this misplaced notion of having to, right now, today, deal with the next 50 years' worth of debt by concentrating specifically on medical care. But there are other aspects of medical care that we as an academic medical center also face. That has to do with the fact that we train, 16% of all the physicians in the country in New York City, and those things have positive externalities associated with them, so that what we invest, gets distributed in lots of different places. And to the extent that GME is going to be a target of potential cuts, that's something that keeps us up at night. Disproportionate share payments is something that's obviously in the target areas of folks, and that keeps us up at night. So to the extent that lots of decisions are getting made beyond our control, we feel perfectly comfortable in managing care for very poor, ethically diverse, very sick people. We don't have a problem with that. We do that. We think we do that well. We think we've got it down. It took us some years to do that. In the beginning, we were losing money, but we figured it out, we think. But what is a little bit of a worry to us is that there are decisions that will be made with regard to these issues that are completely beyond our control.
A lot of it's the external revenue reimbursement, things that could happen for the academic medical center, training residents, and so forth, things that really just are outside your control. You're doing great in your local market, doing great at delivering care, but it's those external things that could have a big impact on your ability to have a great top line that works. Barb?
I think it's pretty consistent in Illinois. Illinois is the 49th worst paying state for Medicaid, and they don't pay their bills, sometimes for a year out there, or their insurance for the elected officials. who
So
are-
not the worst state.
That's correct. It's not the worst, but it's pretty darn close.
The,
But, I think, we know what we have, and with the sequester and all, in Illinois, with the state of Illinois, and then with the federal, it's the decreased reimbursement for Vista, because we take care of the richest to rich and the poorest to poor. So I think, and then competition with the Blues. The Blues are contracting with some of the big systems, and again, you don't want to be cut out of those if you're a smaller entity.
I learned a long time ago you can't control what comes out of Washington, but actually our biggest challenge is the opposite of our greatest asset. So in 2008, Mercy received from George Bush in the Oval Office the Malcolm Baldrige National Quality Award as the first vertically integrated health system. And Baldrige identified our W2 physician partnership model as a role model best practice for physician integration in partnership. But having all these hundreds and hundreds of subspecialties, we now have to get them to do what they're saying to us is cutting into the bone and the muscle. The fat's been eliminated. So we had Milliman Robinson, which is a physician actuarial firm, come in and meet with all of our doctors, and Milliman Robinson said 70% of the care you're now providing are unnecessary. So it's that leap of getting the physicians to understand that there's so much more we have to do in the way of getting more efficient in our quality of care.
Gotcha. Now, for both, I see a Theta Care leader in the front row. So if you or Linda have anything negative to say about Theta Care,
I wouldn't dare do that, but what I want them to do is I'm doing a breakout session right after this on the secrets of my physician partnership model. I don't want him there, so
great,
make sure he doesn't
great.
show up.
I want to thank our panelists. Just terrific. I know that I hope all of you guys will be available for a few minutes for questions afterwards. But Nancy, Linda, Andrew, Barb, Javon, just a pleasure, and thank you